Keynote speaker, Suzy Engwall, is here, and she's a nationally recognized healthcare executive, board leader, advisor, and has deep experience driving change and driving innovation across complex health systems. There you go, Suzy. Are you ready?
Yes, thank you, Yuli, for having me.
Can,
And thank you guys all for hanging in there. I know it's late, especially on the East Coast, so I appreciate everybody that's here. Let me get my screen share going. Can you guys
so,
see my screen
Su-
okay?
Suzy has been a great, yeah, we can see it. Suzy has been a great advisor to us at InnovatorMD and also a mentor and a good friend. So, welcome, Suzy. It's a pleasure always to have you and to be able to learn from you.
Well, it's always a pleasure to see you too. And I don't think there's anything I'm going to say tonight that's not groundbreaking, but there are challenges in healthcare, right? So I'm going to start with a little bit of a small confession. Having worked with in the startup world, working with health systems for the last 2 decades, I will say in the beginning of all of this, I kind of thought, I had that field of dreams mentality that if you build it, they will come, right? And we all know that over time, you start to learn that that's just really not the way that it is. So after all this time of working with startups and health systems, the main thing that I've learned is that in healthcare, being right about the next technology almost never decides what happens next, right? What decides it is whether the systems, meaning the people, the workflows, the culture, the committees, are ready to receive it. So tonight I'm going to talk a little bit about that gap and the space between a great idea and actual adoption. And I know I only have 20 minutes, so I'm going to cover three things tonight. So we'll go about an inch wide or an inch deep. But I'm going to be honest with you about all of them. And it's not to discourage those of you that are building in healthcare, but it's because I think you deserve to know the truth about what you're building into. So I'll talk briefly about what founders most commonly underestimate. We'll look a little bit at the gap between innovation and operations and what it actually takes to kind of bridge that. And then we'll talk a little bit about something that doesn't really show up in pitch decks. That's leadership and trust. And how do we build those bridges with health systems? In my experience, it determines more outcomes than the innovation you're bringing forward, believe it or not. So it's really important. That's something we think about. So at an early stage, founders tend to focus on getting through FDA. I just have to get through FDA. And I see a lot of founders when they're pitching to startups and or when they're pitching to investors, checking off the boxes for what they think investors want to hear in those pitch presentations. And then they go back to that singular focus of I've just got to get my product built and get through FDA as if it's some sort of end goal. It is a huge milestone, but it is never the end goal. It is the beginning. And I can't emphasize that enough. And most of you probably realize that by now. But lots of companies make it through FDA. Some estimates suggest that as many as 75% of the devices that do make it through FDA still fail commercially even after approval. I want you to sit with that number for just a minute, 75%. I want to be clear about why that happens. It's almost never because the technology was bad. Most of the time, these are real solutions to real problems. They're built by smart people. They're piloted at respected institutions, but a lot of times the systems just aren't ready to receive them. And that phrase, ready to receive, is the frame I want you guys to carry with you as I speak tonight. Because adoption isn't always about your product. Obviously, it's about the product first, but it's really whether the environment your product lands in has things like the infrastructure, the trust, the process, and even the will to absorb it into what they're doing every single day. So I know that's a pretty scary stat, but I think we can all overcome it. Did I go backwards? Sorry, I go backwards. So specifically, we're going to go through these three things we talked about. So the first one is what founders underestimate. And there's a lot. Like we said, we only have 20 minutes, but in my experience, it kind of comes down to these three things when you're talking about adoption into hospitals. The first is really this workflow inertia. And I heard, the last speaker talk a little bit about workflow integration, which I was so happy to hear. Clinicians aren't resistant to change because they're stubborn. They're not trying to say we don't want to use your device or your technology. They're resistant because they're in an operating system where every single extra click, every new login, every additional step has a cost. And that cost could be in time, it could be in attention, it could be in patient care. And if your tool does not fit into that existing workflow, it will likely be abandoned, even if they love what it does. So remember that. You've got to make sure that you fit in nicely into that workflow. The second, and again, this is no magic recipe. You guys are all aware of these things, but it's surprising to me how many people get to the workflow space and then realize that they don't fit into the workflow. The second is procurement and the complexity around it. So I can't tell you how many founders have said to me over the years, we have a champion at a major health system, yay, so we're golden. Well, your champion's goodwill has a shelf life, believe it or not. People move on, things happen. So before your product goes live, it needs to survive things like an IT security review, a compliance audit, legal reviews, budget cycles, sign off from value analysis committees that most likely only meet once a quarter, sometimes monthly if you're lucky. It feels like an obstacle course, but sadly, it's not the obstacle course. It is the road. It is the path that you have to navigate. So learn to love it, learn to navigate it, but know that we're looking at sometimes up to 18 months of buying cycle time, really depending on what your product is and the hospital that you're trying to sell it to. And the third, which I think is one of the most important, is the human change equation or the people equation, and specifically even politics. People, like I said, don't resist technology. They're resisting uncertainty. They're resisting the feeling that something is being done to them, not with them. Adoption is always people problem first and a product problem second, in my opinion, in my humble opinion. So let's talk briefly about a good example I have of this one. You guys have probably all heard of Pear Therapeutics. It was a company that had amazing technology, clinical validation, but it completely missed product market fit. And most of this was due to people, the human equation, and that need for behavior change. Their tech was brilliant. So if you don't know who they are, they had smartphone apps that delivered evidence-based interventions. They were an FDA prescription app, which I thought was really interesting for substance use disorder and opioid use disorder. They had strong clinical data. They even had a first mover advantage in the digital therapeutic space. Their clinical need was obvious and there. The opioid crisis was killing, I think, around 80,000 Americans annually. Substance abuse treatment had massive gaps, and they had a scalable intervention that could reach these patients anywhere. How exciting is that? I probably would have written them a check at one point. But they failed on product market fit in healthcare because of these human factors. First of all, doctors did not know how to prescribe an app. So that required behavior change. There was no integration with existing treatment protocols that involved this workflow inertia and these workflow challenges that we're talking about. And it added complexity rather than simplifying care, which means doctors didn't want to use it. On the patient side, patients that they're working with are struggling with addiction. They often lack smartphones, or even if they did, then maybe they didn't have reliable internet. The app required them to engage with it daily and during their most vulnerable moments. So if you're competing with addiction for attention, who do you think is going to win? If I've got 5 minutes and I'm feeling that itch, am I going to go to my addiction or am I going to go to my phone? The list goes on, but a lot of the challenges that they had were people problems. They were, in the end, and despite FDA approval and the strong clinical data they had over $200 million in funding. So this was not a company that was short on skill set or short on having a good technology, but they ended up filing for bankruptcy in 2023. And this is a perfect example where clinical validation kind of fell without product market fit. And a lot of it was due to these reasons. So it's something that we really have to think seriously about what you're underestimating. Moving on quickly to point 2, because we are short on time today, bridging innovation and operations. So there is a great gap between having a great demo over here and a live deployment, which is where most startups kind of start to run out of runway. And this in here, this kind of red box over here, this dome of death, is kind of where I feel like where most startups kind of run out of runway. So I broke this down into 5 little simple frameworks, right? Discovery, pilot, validation, scale, and adoption. Most founders can get through a pilot pretty well. Almost all of them know how to run, a proof of concept with a small team. It's something that, they can get pretty skilled at pretty quickly. But when you look at what I've highlighted, that red zone, it's from the pilot to validation to scale is where I've watched companies die. And it's not because they failed, they succeeded at the pilot. They just couldn't figure out how to operationalize that success across a much larger complex system or a much larger complex hospital. At the pilot stage, you're working with early adopters. They're motivated and they're usually kind of forgiving, a little bit more forgiving than maybe, being used in everyday practice. And at validation stage, you need those skeptics to buy in. So the skeptics are people like the charge nurse who's seen 5 transformational tools come and go in the last year, and was worried the next thing's not going to stick around. You've got the IT director who's worried about your API, and the administrator who's looking for ROI on top of clinical value. There's all of these players, and you need all of them to buy in to really scale. So you need the institution itself to kind of own it. And that's why I go back to a champion here is not going to be enough. You need to outlast your champion and be able to stand up against these solo loud voices. And I actually have a startup going through this right now that I'll talk just briefly to. They're in a hospital, they're ready to scale, they've had amazing results. They've got one nurse who really hates the technology and is screaming at the top of her lungs about how much she hates it. And it's caused them problems. I think they're going to get past it. I think they're going to make their way through it. But you can have buy-in from hundreds of voices in a health system or in a hospital and have one that really dislikes you. And if that person has enough sway, politics can shut you down. So these things, you can start to see how kind of this slide intertwines a little bit with our last one when you're talking about politics and scaling and innovation. So when you're thinking about how founders look at things versus the hospitals, I love founders. I work with them consistently, but there is a sort of this persistent gap in how founders and operators understand the same situation. So a founder might say the data speaks for itself, but an operator saying which data from which population, how does it compare to what we're doing already right now? What does it compare to the protocol? And hasn't been validated in a system like ours. Maybe you tested it over here, but our system's different. And a founder might say, our champion's going to drive adoption. And then the operator says back, well, guess what? Our champions leave. They get promoted, they burn out, they move on. You need institutional ownership, not individual enthusiasm. So I'm not saying the startup mindset is wrong. It's that optimism that makes you guys founders, right? That's why we love you. But you need to be fluent in 2 languages here. You need to speak product and you need to speak operations. Hopefully that makes a little bit of sense. And then my third thing is really talking about your technology being, having this true level of trust. So if your technology is the vehicle, trust is the road that paves the way. And if the road does not exist, it doesn't matter how good or fancy your car is, you're not going to get to your destination. So this is what I kind of call the trust stack. So at the foundation, we've got safety and compliance. Will this hurt my patient? Will this expose our institution? This is a non-negotiable. You cannot build anything above it if you do not have this safety and compliance trust along the bottom. Above that, you've got workflow trust. Is this going to make my team's job easier, or might it become harder? And this is where you really have to be honest, because sometimes it might be harder at first, but then it's going to get way easier. And if that's the case, say so. When I see companies come in and say, oh yeah, it's going to be so much easier, we're going to save all this time, and then they go into this really hard like learning curve or operational curve, you're going to lose people. So be honest about it, give a realistic timeline, and do not oversell. The worst thing you can do when trying to get hospital adoption, when you're trying to build trust, is to overpromise and underdeliver. Above that, we've got outcome trust, and that is really, does the evidence apply to that hospital system or that entity that you're trying to get into? Is the study population similar to the patients they have? You're going to have to show operators how to interpret the outcomes data so that it's in their context, and that's how you're going to build that outcome trust. And then hopefully you get all the way to this 4th pillar, this top, which is relationship trust. And those are things like, does the administrator believe that your company is still going to be here in 3 years? Are you going to be responsive to them when something breaks? Is somebody going to be there on the floor helping them learn as they're implementing your technology? Are you as a founder going to treat them like a partner and not an account? If you can have the best product that's on the market and still fail if any layer of this stack is missing. And I'll give you a cautionary tale and to show you that even big companies fail at this. This is not something that you can take lightly. So let's think about IBM Watson for oncology. You probably all have heard about them. They had one of the biggest brands in tech, unlimited resources, fantastic partnerships. Some of the most prestigious cancer centers in the world were signed on with them, and their product still failed. And every single layer, in my opinion, of this trust stack was compromised by them. So relationship trust collapsed first. MD Anderson paid $62 million for a system that was never deployed at scale. And when it came to Watson's recommendations, they were trained on hypothetical cases, not real patient data. And that relationship trust really evaporated instantly because of that. Outcome trust was never established. In 2018, an investigation found that Watson's recommendations were frequently conflicted with the tumor board's own conclusions, so clinicians didn't trust it. Workflow trust was never built. Oncologists reported that it was cumbersome and didn't fit how they actually made decisions. And then safety and compliance trust, it all boiled down to that, questions about whether the training data reflected real patient populations. So you don't need to be as big as IBM to make this mistake. You just need to skip a layer. So you cannot skip these layers. These are important things for you to have. Politics plays a huge role in this too. So I know I've been focusing on what you're doing. I want to acknowledge one thing. All the things that I've been talking about really requires leadership of the health system to work, and not all health systems have it. And this is why it's really important for you to have a good go-to-market strategy and understand who you're selling to when you're initially rolling out to market. The best innovation outcomes happen when you have an internal leader who does these 6 things on this screen. But and it sounds like they might be unicorns, right? They're the people that can name the operational problem, their problem in operational terms. They provide air cover for you so that teams can pilot without fear of punishment if it gets messy. They amplify early wins. They are closing that feedback loop so clinicians know their input was heard, and that's a hard thing to get leadership to do. They treat vendors as partners, and these are all things that people are saying, that's great. How do I find these people, right? If you're evaluating a health system as a potential customer, you need to look for these signals, but they're not common. And I'm not going to pretend that they are, but they do exist. So one really good world example is Dr. John Halimka. He's the president of Mayo Clinic Platform. He's built a reputation for being exactly this kind of leader. He names problems in operational terms. He creates structured pathways for startups to partner with Mayo. He plays the long game, not the short game, right? He's not just looking at this as hey, let's play around in the sandbox for a couple months and then I'm going to move on. And he's known for treating innovators like partners. So founders who cold pitch to Mayo may have a harder time than founders who do things like finding this doctor's public writings, engaging with his ideas early, showing up to the right conferences, and starting to build a relationship before asking anything. They're more likely to be the ones that are set up for success. So find those champions in those hospitals, follow them online, start to look at what they're doing and how they're exhibiting leadership, and then make sure that you start to engage with them and build relationships with them, because you're going to succeed much better when you've got somebody like this on your team. Again, it's hard to find, not impossible, but something that you really need to kind of do if you can. So really quickly, how much time do we have left, Yuli? You're on mute, so I'll assume.
You have 4 minutes.
Okay, 4 minutes, perfect. So you've heard a lot of the challenges that I talked about today. Here are 5 things that I really think successful startups do differently. The first thing is that hire for operational fluency. So not just an MD or a PhD, hiring people who've run a clinical unit, or putting people on your advisory board who've run a clinical unit, who've managed a hospital budget, who've sat in those procurement meetings, somebody who can translate the operational side of things for your company. Doesn't have to be everybody that you hire. It has to be one person that has these skill sets. They map the full committee. So it's not enough to just say, hey, I have a champion at X hospital and they're going to get me in. Like I said, those champions leave. So on day 1, start kind of drawing out that org chart of every person in the hospital that can say yes. And hopefully your champion will guide you on that. Who are the people on the value analysis committees? Who are the people that are making those buying decisions post-pilot? And build a strategy for each one of them. So you've got kind of your value props built out for all of the key players. Make sure that they align with the people inside of that organization. They design an evaluation period into the product. So make it really, really simple for hospitals to run a 60-day pilot with a structured readout and remove kind of that friction from that prove it phase and build it into sort of your sales. They measure what operators care about. So operators don't necessarily care about the same things that investors cared about when you're seeking funding. They care about things like staff time saved, readmissions avoided, documentation burden reduced, not just having clinical outcomes that look good in a journal, but real, true organizational impact. And then number 5, they earn trust before asking for scale, which we kind of just talked about on the last slide. So one really, really deeply successful implementation that's fully supported, to me, beats 5 shallow pilots every single time. And so the more that you can do of these things, I think the better off you're going to be. So with that, this is kind of my last statement, and then I'll close it out for questions. In my opinion, healthcare does not reward the fastest innovators. It rewards the one that is trusted. So let that sit with you for a moment. Build something ecosystems can actually absorb. Earn the trust before you ask for the contract. Build those relationships and be the partner to the health system that they didn't know they need. I've seen companies do this really well, and I've seen them do it very poorly. Be the one that shows up, not just at the sale, but at implementation, at those hard moments, and at that 12-month check-in, 6-month check-in, 18-month check-in, when everything sort of gets harder than everyone expected. And with that, I will take any questions that you guys have.
Thank you, Suzy. That was great. One of the questions, I'm sure you must get a lot of these questions. So innovation can happen, within the system, right? And then innovation can happen outside the system, where you're not depending on the current system to support you and to buy into what you're doing. What is the major difference between the two? I know this is hard. This is harder too. But how do you assess?
I've been on both sides of it, Yuli.
I
So,
know.
I was
That's
at an
why.
incubator for 6.5 years. And I will tell you, like, even innovations that are built by clinicians inside the system don't always get used by that health system. I can think of many right now ideas that came through Innovation Institute when I was there that are out on market, and the hospitals that invented them aren't even working on them. So I think there's a couple of different things. When you are an entrepreneur, when you're inventing from inside the hospital walls out, you really have to make sure, number one, that your hospital is going to help you and buy in with you. Because what I've seen is even hospitals' innovation programs, doctors go out on their own. They're like, my hospital's not helping me enough. I'm done with this. I'm going to go out on my own and seek funding and build this myself. And then they'll jump through whatever hoop they have to do to make sure they own the intellectual property, right? Hospital is not a hospital is not a hospital. And an innovation program does not equal an innovation program at every place. Some are much better than others. But regardless of whether you build from internally and then go out to the market and try to sell, or whether you build on your own, number one, you'll probably move faster building on your own, believe it or not. It sounds counterintuitive, but that's probably the case, because you're not going to have the constraints of people in the hospital telling you can't do certain things. But number two, you're still going to have to go out, no matter how you built it, and get a market adoption. And sometimes I think when you build internally, it can be a little bit harder because you're building specifically for your health system. And now you got to go out and sell to people who might do things a little bit differently. So there's a lot of challenges. I mean, that's something that I could probably talk about the whole rest of the night if we had time.
Thank you. All right. Laura has her hand up. Laura, unmute yourself and ask the question.
Thank you. Suzy, that was a fantastic presentation. I've worked in innovation in healthcare and have encountered a lot of these things that you're talking about. And I don't know if it's possible to answer this question. So you talk about finding a healthcare leadership that offers the helping hand and all this stuff. And typically the good things also they would do is help you to get through legal, get through IT, get through all of the guardrails within the large organization. So my question to you is, why isn't it that healthcare companies don't sustain like teams of people who do that? I've been on a team like that but they tend not to last very long. And I wonder, is it just hard to measure the ROI, or they just fall out of fashion? What do you think about that?
Yeah, I mean, I think it's a couple of things. So, I think sometimes hospitals have that opinion that, oh, we've got a value analysis committee team. They're evaluating everything. We don't need other people, right? So that's one thing that I think happens. I think the other thing is it is hard to justify the ROI, right? Somebody has to pay these people's salaries. And we all know that when hospitals have shortfalls, their go-to is layoffs, right? The first thing they're going to do is get rid of the people that aren't at the patient bedside or aren't producing some type of income. Yeah. And even with innovation teams or with teams of people that are kind of put in place to help bring in new innovation, getting ROI back from that can take years. And so I think it's not that I don't think they mean well or that they don't want to. I think we're living in an age where hospitals' profit margins are very slim, and they're going to do whatever they need to do to make sure that they can keep going at the patient bedside. And we all know that also trickles down to the nurses too, right? It always feels like wrong to me. I'm like, the nurses lose their job before the administrators, or before the administrators take a pay cut, right? Well, they're gonna get rid of the other people that aren't in those roles as well. And I think that it's just a side effect from the way that they now make money. I mean, that's my personal opinion. I don't know, Yuli, you might have something to add too, but so feel free to chime in if you'd like.
Totally agree. All right, Joe, you're up next.
Yeah, Suzy, thank you so much, as always. Just wonderful insights. As I engage with early stage companies, I'm often asked, how do I go about doing this type of market discovery? We have a limited team. I'm not very well known. I don't have connections the way that, some experienced folks do. How do you recommend that early stage companies go about market discovery so that they're not learning these things when they've already invested a lot of time and effort into building something incorrectly?
It's hard. It's really hard. I mean, if it were me and I had $0 and I was building my own startup from the ground up, the first thing I would do is try to use a data-driven approach to understand who are the first 5 hospitals or 5 clinics or 5 whoever I want to go after, right? Not everyone. I think one of the downfalls is I hear people talk about their go-to-market strategy and they're like, we're going to go after every hospital in the US, or we're going to go after every hospital in Colorado because I live near 5 of them. But there's no data-driven approach to it. Is the hospital doing the types of procedures that you need to bill for, or that your device is helping with? Have you looked online to see if they've got what their annual plan is or what their strategic plan is? A lot of times they publish a 5-year strategic plan, and there might be something in there that they're like, oh, they have a goal to reduce whatever. They have a goal to reduce sepsis patients or whatever that looks like. They've got this goal. And right there in here, it tells me that this person's in charge of it. And they've got, within 5 years, they're responsible to do X, Y, and Z. I can help them directly with that. So start reaching out to them on LinkedIn, start looking at the conferences that they're going to, try to put yourself in the path of those people to make those introductions and to start meeting with them. And don't come out with your ask right away. I mean, nobody likes it when you're on LinkedIn and somebody you don't know reaches out to you and they're like, hey, do you want to buy my product? Instead, it's like, hey, I noticed that you work in, you're a renowned physician in diabetes, and I have this great product. I'm really interested in it. I'd love your feedback on something. Would you mind giving me 5 minutes of your time? Or I just want to engage with you and connect with you. Those really like low level, or not even an ask right away. I think it's important because, even going to conferences, they're expensive. A lot of the clinicians and physicians come and sit on panels and leave. They don't stay around where you can talk to them and meet with them. So you've got to utilize the resources that you can. And there are free and easy things out there that you can do by engaging in social media platforms, by looking at the hospital and understanding what their needs are, what types of things they're doing, trying to use AI to dig out as much data as you can. You'd be surprised what you can learn by just putting in a few queries and saying, hey, who are the top docs and where can I meet them? I've learned a lot about physicians and reached out to them and gotten responses just by doing a little bit of digging that way. It's not easy. It's definitely not without a resource. It's a great question. So if anyone else has input, feel free to give it.
Thank you. Thank you. That's a great answer. All right, Naidu, you're up next.
Thank you, Uli. Suzy, as usual, a great presentation, pulse of wisdom, and I have some scars to prove in many of the points that you have said are true. We are living for last 5 years or so. One, you said one nurse is there may be a deal falling apart, but they may come through. Any insights that you can, in one of the health system, we are not from a nurse, but deputy CIO, we are facing the similar issue for non-valid reasons, and but everyone else is there, and the guy, the champion, still wants to move forward. So he and I have been having a conversation of me and him, the champion, directly going to the president of the hospital and getting it done,
Yeah.
despite the objection. But for me, even I want that deputy CIO to be, or CMIO to be onboarded with our platform. So.
It's hard. It's hard when you've got like one naysayer, especially when it's somebody that you need on your side. And I think really the only way, sometimes, I hate to say this, but sometimes you just have to jump ship and go to another customer so that you can get what you need and then come back to them and say, look, I did this with this health system. I know you don't believe in the technology. Can I just have 5 more minutes of your time to understand what your challenges are? How can I work with you? I think, people like their egos stroked a little bit. And so I think when you encounter somebody that's difficult about it, the adoption of your technology, the best way to do it is to not get mad, even though you might be mad on the inside, is to really, try to understand from their perspective, what are you having a challenge with? And I would ask them flat out, like, look, I know that you have, said these 3 things. I've done everything I can to show you that why this isn't the case. What else can I do? What other hesitations do you have? What other things can I ask? Sometimes it might be somebody who's not influential enough and you can sidestep around them. But I've seen things be shut down at a value analysis committee just because somebody in procurement doesn't like it, or somebody that the worst thing I ever saw was we had a deal set up with a hospital for a project to build some innovative technology together, to co-create something together. And we had everybody ready to sign off. We had contracts in place. Lawyers had reviewed them. Everybody was a gung-ho and ready to go. And in the 11th hour, they're like, hey, let's bring marketing in so that we can figure out how they're going to support this initiative and talk about it. The marketing team, the one person on the marketing team, shut the whole thing down. She said, I don't like this. We can build this ourselves, blah, 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 blah. And within 2 hours, the whole thing was dead in the water, never to come back. And it's been multiple years since then, and they never built it themselves. But you just don't know. And that's what makes this so hard, right? Because sometimes people that you think wield no influence whatsoever can shut the whole thing down. And I think it's just really about knowing when to cut your losses, or when to say to your champion, hey, let's keep working together. Let's try to figure this out together. But at the same time, can you help me with any other place? Are there people they're friends that you have that could champion us, another organization where we could prove this out and then bring it back to try to win this person over? It's really, really hard, and it stinks. It stinks that one person would have that level of influence, but it does happen, and I'm sorry that's happening to you.
No, that you are spot on. The minute that guy raised that, and his neighbor, which is even a much bigger health system, this is not a hospital; it's a 15-hospital health system.
Yeah.
But we are doing exactly the same thing. The guy, the CIO of that organization, now is saying that, hey, I can talk to the other guy. That is not an issue. We are doing it. So we are approaching all, but
Yeah.
thank you.
And sometimes too, sometimes people are worried about they're going to be discovered for a flaw that maybe they have. And I know the example that I talked about earlier, the reason this one nurse didn't like this technology is because it was starting to expose some nursing errors that were happening. And most of the nurses were like, oh, this is great. I didn't realize this was going on. But this one got really defensive and really vocal and really loud. And so tried to find all these reasons to shut it down. So sometimes it's a personal thing. But yeah, that's why these politics really matter. And that's one of the things we just don't talk about as much.
Yeah.
Thank you.
Maybe you should take them out for lunch or beer or something.
I like that. This is always the right answer.
I'll usually invite them to come speak at my conference.
I like that. Smart.
But yeah, this is great. Any other questions we have? Oh, we're out of time. Sorry, guys. This is a pleasure. We can hear you speak all day long, Suzy, because every sentence has a nugget in there and some words of wisdom that you shared today. But
Well, good. I
thank you
hope it
very
was
much.
helpful. Yeah, of course.
On behalf of everybody here at InnovatorMD, thank you very much. And we appreciate the work you do, for the industry and also for innovation. Keep doing what you're doing, and let's connect afterwards, maybe next week or so.
Yes, absolutely.
All right, everybody, the startups, amazing startups. Thank you very much for presenting. We wish you good luck. And if there is anything we can do to help you connect or help you take the next step, you know me, I can be reached, and my team will be happy to help you do that. But otherwise, have a good night, and thank you very much for being here.
Thank you.
Thanks, Yuli.
Thank you.
Bye bye.
Yeah, bye bye.